Okay, so we're looking at an isokinetic test, and we're just going to go down the metrics. So there's certain metrics that matter, and there's others that don't. So let's talk about the ones that are most important. So peak torque is definitely important, right? This is like why we do that, or do the test, right? So peak torque is like how much force someone produces. And when we look at our two columns, it's given to us in foot-pounds. This is also commonly done in Newton meters. That's just the metric form rather than the English units. And foot is like the distance of the shank. Pounds is obviously the force produced. And torque is a multiplication of the two. In this instance, we have knee extension, we have knee flexion, and we have 3 columns for each. We have an uninvolved limb and an involved limb. And there's a 10% discrepancy between the two, with the involved limb being slightly superior in this case. The next metric is also important to us. So this is peak torque to body weight ratio. So there's good norms that have been established based off gender and age for this metric. And it's actually a really robust metric in order to predict someone's return to activity, but then also it's important for longevity. So when we look at someone's potential for vitality later in life, their peak torque to body weight is critical. And then you could even use peak torque relative to fat-free mass, but you would need a DEXA in order to get that. So why is this important in like a post-injury individual? Is because oftentimes, let's use the classic example of like ACL or lower extremity injury, is that even the uninvolved limb can go under a 30% decrement in its strength because of the hiatus of activity and the lack of training that results from the rehab phase of recovery. So we can't. That would leave us to compare the involved limb, the injured limb, to a weakened uninvolved limb. And so one way that we can normalize that to overcome the error that may occur just by looking at limb symmetry or of peak torque is looking at peak torque to body weight. The next is a metric, it's kind of a surrogate of rate of force development. It's time to peak torque in milliseconds. So oftentimes I find that the Isokinetic software puts this out because it gives a perception that their software is able to capture that value, but there has been called into question through the validity of that actually being rate of force development that you can actually hang your hat on, because it's rate of force development is such a volatile metric that usually you need a rigid shank in order to do it, meaning like an isometric test rather than an isokinetic one. The second is that this can have the flaws of like the individual pre-tensioning. And then what they've also shown is that your cueing matters to the patient. So you can't get an accurate rate of force development off a test that's sole purpose is for just peak torque, because the instructions that you give to the patient actually matter. So if you're looking for peak torque alone, you would say, I need you to push as hard and fast as you can, with the emphasis on hard and coming first. If you wanted rate of force development, you would reverse that. I want you to push as fast and hard as you can. And so these next couple metrics that you see where you're looking at time to peak torque and torque at 0.18 seconds, really, again, they give you a gross estimate, but they're really not the most valid metrics when we're considering rate of force development. And as such, I'll just highlight them in red. They're noteworthy, but really not too important because of their invalidity in an isokinetic test that's intended for strength. Angle of peak torque is noteworthy. This is like at what the knee angle is when they're achieving their peak. And you can see for this individual, regardless of knee extension and or hamstring, or that is knee flexion, that they're about the same. The other thing that it can be noteworthy is peak torque at 30 degrees. Why is this important? Is because when we're hitting the ground with running, for instance, oftentimes the knee flexes to about 40 degrees or so. And so this is like kind of smack dab in the middle of that excursion angle. Additionally, this can be the point at which patellofemoral-based patients will also get some of their irritation. And then it's also known as the iso point, so the point at which the quad is at its greatest length tension relationship. And so, interesting for this individual, even though she pushed, her peak torque achieved 9.1% superiority on the left leg. That is the involved. She had like a 10% decrement at that 30-degree mark. All right, coefficient of variance is something that you'll want to take into account because it helps you to answer the question as to whether these results are valid. So at times you'll see that the coefficient of variance will exceed anywhere between, gosh, I've seen it as high as 50% in individuals. So this really indicates a couple of things. Specifically what it indicates is variance between her repetitions. And this can occur for a variety of reasons. It can occur because of fatigue. It can occur because of pain response that occurs during the test. It can also occur because of a learning effect. In certain instances, I've had colleagues who have had people actually try and botch their uninvolved limb in order to pass the test to return to sport or activity. In such instances, that would show up in their coefficient of variance as being quite high because they're volitionally tapering their load or their effort. So next is max rep of total work. Like how much area is under the curve. This is also known as like an impulse. And so her max work is actually pretty similar, and again, superior on the left. Max work rep just tells you which rep that is. Work to body weight, also valuable. I don't put much weight in the work. However, it does have its merit in some patients, and I can show you an example of that. And then total work is taking the totality of the work over all of the repetitions in that given set. And so this could, if you have a longer set, then you could consider this to be an element of fatigue. And that is also captured in the work in the first third and the work in the last third, and then the percent of work fatigue. So this is the work in the first third of the set, the work in the last third of the set, and then the difference between the two. So you can see that in her involved limb, she had a little bit more fatigue, about 30% versus your 18. Okay, average power, again, something that's captured. I don't take much stock in the watt output here, but it is something that's otherwise captured. Again, acceleration and deceleration time, nice to know. I don't have any clinical relevance for this. Range of motion just tells you the arc that was set for that knee. And that's when you're setting up the test. Now for the knee, it doesn't have as much of an implication, but for instance, if you're doing someone's shoulder and or their ankle, this matters greatly. Significantly because, like take the ankle for instance, someone's peak torque is well into their dorsiflexion range of motion. Rather than, so if someone has limited dorsiflexion, then they may have an artificially tapered plantar flexion peak torque because they're not achieving that degree of dorsiflexion. Okay, a big shout out to Rich Willie, who does some wonderful research in the running field. And so if we're so this is the prime example of what I was describing with the dorsiflexion. So you have the soleus force output on the y-axis, and then you have the different peak torques that are achieved within on the x-axis. So when you prescribe an exercise for someone when they're just doing their calf raises off the floor, you're strengthening this portion of their soleus. But what actually matters, and hence why the biology has adapted such that your peak torque is at 20 degrees of dorsiflexion, and even at times can be deeper than that. So knowing the strength curve of the joint in question really matters. So if we go back to this, right, and we're looking at the range of motion, and we can see that someone has like, I don't know, like 50 to 70% of the range of motion, and we're testing an ankle. One, their peak torque may be artificially dampened because they can't get that pre-stretch in the plantar surae or tricep surae, and we would also pick that up in their angle of peak torque, would also give us some indication of this. The final two metrics that we see here are average peak torque, which is taking the average over all of the repetitions rather than just the peak torque, which is taking the best repetition and the highest peak torque achieved. And then agonist and antagonist ratio, which when we're talking about the knee matters. So we can see in the first column 55% and then 51% respectively. What is this saying? This is giving us our hamstring to quadricep ratio. So it's taking our 32.9, dividing it by our 61.3, and giving us 55%. The G colon gives us a guide and a good barometer to shoot for females, where we would expect them to get to 62% relatively hamstring to quad ratio at this speed of 60 degrees per second. And that is the kind of the rundown of the comprehensive evaluation for the isokinetic. Now, this being said, some of these have clinical merit and some of them don't. An example that I did want to just highlight was with the total work. So in instance, this is something that I often don't use. But a primary example where this would be applicable is where you have a pathological curve. And a pathological curve would look like this. So here is an instance where it's actually a progress report. So we're looking at the individual's involved limb, which is his left to his involved limb. So his uninvolved limb has a full curve here. And so though his peak torque, here's the example where you have your involved limb, that is the pink, to the uninvolved, which is his blue, which is his right leg. So if we just stuck by like the numbers that are often touted, his peak torque, it's like, the guy's looking pretty good, right? He's at 12.3, but when we look at like max rep total work, he's at 22. And why is this the case? Is because he has this pathological curve where he has a dip and then he falls off. So as he nears closer to mid-terminal knee extension, his force production drops. Now, you have to inquire a little bit more when you see such results, right? So you have to ask the individual, like, if they're having pain or, like, what and if so, that may explain the inhibition. If they have, at times, these curves have been diagnostic, though their sensitivity and specificity has been called into question at times in regards to diagnosing like ACL deficits and or meniscus injuries. This individual just has some moderate to significant with a varus deformity knee osteoarthritis of the medial compartment. But if I was only to say, if he was to ask me if I could run and I only go off my peak torque, I could be fooled, and he likely would come back with some form of knee effusion. And so we would need to more work needs to be done to fill out the area under the curve. And this is where at times the work matters, because every time when you look at work and or his power, right, that's where he's in significant double digits compared to just the moderate or mild deficit that we see at the peak torque at 30 degrees and at peak torque there.